Kia ora koutou, kia ora koutou katoa. Nau mai, haere mai, welcome all to this update on COVID-19 in Aotearoa, New Zealand. I'm Andrew Old and I'm joined today by the Ministry of Health's Chief Science Advisor, Dr. Ian Town, and Te Whatu Ora National Medical Director, Dr. Pete Watson. Thank you both for your time today. I will start by providing our latest assessment of the COVID-19 outbreak before moving on to what we can do to best protect ourselves and our loved ones over the coming months. I will then hand it over to Pete, who will cover the work underway to address pressures on the health system now and also looking ahead to the summer months. Ian will then provide an update on COVID-19 vaccination, including a recent decision on vaccine eligibility. But first, the numbers. As you will have seen from our weekly updates, COVID-19 cases have been increasing over recent weeks. After 4 weeks of steady increases, the last 2 weeks have seen a stabilisation of numbers, with the 7-day rolling average now sitting at just over 3,000 cases per day. And latest wastewater results also support that trend of stabilisation. However, as you can see here, the number of patients in hospital with COVID-19 has increased slightly as of midnight, Sunday the 13th of November, with 339 people in hospital with COVID-19, up from 322 the previous Sunday. It's certainly too early to say whether the current plateau in cases will be sustained, and as of course was reported yesterday, cases in the last 2 days do show some signs of increasing again. The takeaway is really that the outlook for summer, with more people travelling and with the unpredictable mix of variants circulating, at this point remains uncertain. As always, we will be watching these numbers closely and continue to plan for a possible continued increase in cases and hospitalisations through to the end of the year. The complex mix of Omicron subvariants now circulating makes it more challenging than previously to predict what the future shape of our outbreak will look like. At this stage, there is no evidence to suggest that the new circulating variants leads to more severe disease, but some, such as BQ1.1 and XBB, have shown increased growth advantage compared to other variants. These new subvariants are starting to outcompete more established variants internationally and now here at home, most notably BA5, which, as you know, was dominant recently and is now losing ground, particularly to BQ1.1, accounting for about 78% of cases in this most recent data, with BQ1.1 accounting for about 8% and BA2.75 for about 9%. Overseas, the impact of these new variants has varied between countries, with some experiencing relatively small increases in cases. Encouragingly, in some parts of Europe, a wave of BQ1.1 cases has not yet led to the same rise in hospitalisations seen in previous waves. This could also be the case for us here in New Zealand, particularly given our relatively high level of hybrid immunity from both vaccination and recent infection at the moment. And we're watching closely this relationship between cases and hospitalisation rates. As has been the case throughout the pandemic, our response needs to prepare and plan for a range of potential scenarios, including such as now when the future shape of the outbreak is uncertain. To continue to inform our response, COVID-19 Modelling Aotearoa has provided some updated modelling reflecting the possible impact on case and hospitalisation numbers linked to new variants, as well as accounting for waning immunity and changes in behaviour, which I'll share in a moment. It's important to note that modelling is not forecasting or predictions, and models always have a high level of uncertainty, particularly with COVID, given the unpredictable impact of new variants, population immunity, and now increasing antiviral use as well. Importantly, the impact of antiviral medicines on future shape of the outbreak will be considered by the group with future models. Given the limited real-world information on new variants, many assumptions required for this modelling have been borrowed from those used for the previous BA5 wave, which assume that the combined new variants circulating have a growth advantage of about 10%, which is consistent with what's been observed overseas. It does remain to be seen if these variants will behave in this way in the New Zealand context, but we certainly need to prepare for that possibility. So bearing all of those assumptions in mind, The model shows daily cases could rise to a level similar to our peak in July, about between 10 and 11,000 cases per day. Daily COVID-19 hospital admissions could, under these assumptions, peak at just over 100 admissions per day, again slightly higher than the midwinter July peak, while COVID-19 deaths could peak at a similar level again to July. It's important to reiterate that these are not predictions of what will happen, but are plausible models that help us plan. As you can see on the graph with the grey shading, the confidence intervals around these estimates are very wide. The Ministry will continue to closely monitor the circulation of new variants and trends in case counts, which all feeds into updated modelling and continued updated advice on public health settings. One respected modeller was commenting this week on the difficulty caused by the many variables, noting that while we can say there will almost certainly be a continued rise in cases, the timing and height vary widely depending on what parameters you plug into your model. One other thing I want to note at this point is that reinfection rates are also climbing, now accounting for up to 20% of all new daily infections. Of those, just 1% are within the previous 90 days, the rest beyond 90 days. Those changes are likely related to a combination of waning immunity and the emergence of new variants, as noted. Important to say also that the increase in cases depicted in these models is not unexpected, and we have planned for it. And these shapes of waves are very consistent with the patterns that we've seen internationally and indeed over the last couple of years. Having said that, neither is it inevitable, and there are steps we can all take to minimise the possible disruption of COVID-19 in our lives in the coming weeks. So, 3 factors essentially will dictate where things go next for Aotearoa: waning population immunity, increase in new variants, and the changes in our collective behaviour. Of the 3, the one that we can control is our behaviour. As has been consistent since the arrival of vaccines, the single most effective thing New Zealanders can do to protect themselves from severe disease remains being up to date with your vaccinations. There are currently about 1 million eligible people over the age of 16 who have not yet had their first booster dose, and a further 820,000 people aged over 50 still to get their second booster. If you're due a booster, my message today is book it in before you go on holiday. Secondly, please continue to get tested if you feel unwell. This is important both for yourself, but also to protect those around you, particularly people more vulnerable to severe disease, such as elderly relatives. If you're eligible for antivirals, the earlier you test yourself, get diagnosed and treated, the more effective they are at protecting you. Rapid antigen tests remain free and continue to be effective against the variants currently circulating in New Zealand. We recommend ordering RAT kits in advance of your holiday if you're going to be away from home and taking them away with you. It's especially important to stay at home and test if you are unwell with symptoms and have been exposed to a known COVID-19 case, because the chance that your symptoms are in fact COVID are obviously higher. If that's your setting, please do not travel or take part in events or activities if you're sick or symptomatic. Isolating yourself at home is the most effective action you can take if you are infected with COVID-19 to prevent transmission to others. If hosting events, open windows and doors to ensure good ventilation, or where possible, and hopefully if the summer is a good one, we'll be able to have lots of our events outdoors. Heading into summer, and particularly thinking about travelling for holidays, it's important to think about what you would do if you got COVID-19 while away from home. Plan how you might be able to get home safely, talk through the plan with travelling companions, and if you cannot drive home, it's likely you'll need to stay where you are for your isolation period or find alternative accommodation. Consider packing a kit that contains RATs, hand sanitizer and masks or face coverings, and your prescription medications if you need them. I'll now hand over to Dr. Watson to provide an update on how the broader health system is managing and preparing for the summer. Got a Pete.
Thank you, Andrew, and kia ora koutou katoa. Yes, the recent increase in COVID-19 case numbers is a reminder of the need to remain vigilant. As we know, the spread of COVID-19 widely disrupted hospital systems across the world, And more than 2 years into the pandemic, global health systems are still facing significant challenges in providing essential health service. New Zealand isn't exempt from this trend, and COVID-19 continues to stretch the capacity of our own healthcare. So in Aotearoa, our health system continues to experience serious pressure due to ongoing high demand. Nationally, our emergency department attendances and hospital admissions from emergency departments remains high. Similarly, hospital occupancy is high and the number of patients with a long length of stay are high and remains a real challenge. Here in Middlemore today, there are around 280 patients who have been in hospital for longer than 7 days. The causes include patients waiting for community support or transferring to other facilities such as aged residential care. However, we can assure everyone that work is underway to better streamline patient discharge. Once patients are medically fit, to improve the hospital flow and ensure patients are in the best setting to meet their needs. This will directly impact on reducing the demand experienced in our emergency departments. General practices and urgent care clinics are also experiencing demand for acute care. Staff sicknesses and vacancies across our health system are having an impact, echoing a wider trend as COVID-19 cases have slowly begun to rise again. Pressures nationwide are being addressed by focusing on how we manage the movement of patients through hospitals by prioritising those who need the most urgent care and increasing regional coordination to deliver health services. This includes working with our urgent care clinics to manage those with less serious patient needs. There is an ongoing response from all parts of the system, from GPs and primary care on the front line to our partners in aged residential care, ambulance services in our communities and hospitals, all taking actions to ensure that patients get the care that they need in a timely manner. These activities are accompanied by a consistent approach to performance monitoring so that we can evaluate, monitor, improve and share successes and ultimately keep delivering our quality care to all who need it when they need it. And so to workforce pressures. COVID-19 has been incredibly testing, as we know, particularly when combined with winter illnesses, but also staff shortages. The pressures placed upon our health workforce have been unprecedented. I'll outline shortly some of the workforce initiatives underway, but I do want to reiterate these challenges are not going to be fixed overnight. It will take time to recruit more people into the health sector. And again, I want to acknowledge the incredible work of our health workforce kaimahi, who are implementing on-the-ground responses across the motu, every day, with the sole aim of providing the highest level of care to their communities. The work you do is critical and valued. So what are we doing to address some of these aspects of workforce? Te Whatu Ora is actively leading on a range of initiatives that the government has announced that are focused on bolstering our health workforce. We're training more doctors and nurses, and we're supporting people who have stepped up to work in the COVID-19 vaccination program to also enter the workforce. In regards to nursing numbers, we've doubled the number of nurse practitioners training each year from 50 to 100. We're easing the process for overseas nurses entering New Zealand and the provision of up to $10,000 per nurse in terms of financial support for international nurses to meet their New Zealand registration costs. We're also providing up to $5,000 in support for New Zealand enrolled or registered nurses who want to regain their annual practicing certificate to be able to return to work in a nursing role in the New Zealand health system. This year, the Return to Nursing Workforce Support Fund has helped more than 200 nurses across Aotearoa get back into the health workforce, many of them in aged residential care facilities. We're also boosting general practitioner training numbers. After discussion with the Royal College of General Practitioners, measures have been put in place to increase each year the numbers of GPs training in New Zealand from 200 to 300. We've also taken steps to address the pay gap, to bring the pay of first-year GP registrars in line with hospital registrars, removing one of the biggest barriers for young doctors going into a career of general practice. Elsewhere, we're continuing to do all we can to support our hospitals, clinics and emergency departments and continue to acknowledge the tireless work of pharmacies and other health service providers. This includes making it easier for health workers to move to New Zealand to help address some of the more immediate workforce shortages we have, whether through our International Recruitment Centre, offering a raft of support to health workers looking to immigrate to New Zealand, or the international recruitment campaign that we are launching this month, tailored for foreign workers in countries that have equivalency, and we'll also have a program of separate communication tailored to New Zealand workers who are working abroad to return to New Zealand. We've already seen positive results from this work, with more than 1,900 healthcare workers having applied to work in New Zealand under the new immigration settings that came into effect in July. It's certainly encouraging to see interest in coming here and healthcare professionals arriving. But we have a way to go. As I've said, it won't happen overnight, and the health system cannot do it alone. So back to easing pressure on the health system. With spring and summer here and on its way, we're asking all New Zealand to choose well their health care. So please consider all the options for care. For example, you can go see your local pharmacist for advice on medication and minor ailments, including cold and flu symptoms. We now also have around 400 community pharmacies across the motu who can also supply COVID-19 antivirals without a prescription. People need to remember that many mild illnesses, minor injuries, simple back pain and simple post-operative pain are better served at a local primary care practice or urgent care centre. However, if you're unsure of how urgent your condition is, please make sure you call Healthline and obtain free health advice any time of the day or night by calling 0800 611 116. It's available 24/7, even on Christmas Day. If it's an emergency, always remember to call 111. And finally, of course, summer is also a time when we come together socially. More often, there are more large-scale events and people move around the country in bigger numbers. We need everybody to have a plan to keep well by ensuring everyone makes good, healthy decisions while having fun wherever and whatever we are doing with friends and whānau. But please remember, if you're unwell, stay home. If you're travelling, make sure you're aware of the risk COVID-19 might affect your holiday plans and plan for this in case it happens, including your own self-isolation plans. Also, make sure you have your regular medications before you go away. Remember, for free COVID-19 advice, 24 hours, 7 days a week, you can call 0800 358 5453 or visit the dedicated COVID-19 Health Hub, covid19.health.nz. And so in coming months, we will likely continue to see a high prevalence of COVID-19, but we will get through, just like we have in the past, together. Vaccination, isolating when unwell, testing and self-reporting results, these public health measures which have served us well and will help us to enjoy the summer we all deserve. Kia kaha, kia ora tātou katoa. Thank you, and I will hand over to Ian. Kia ora.
Good, well thank you Pete and Andrew. It's good to be back talking with you about some of our work on the COVID-19 vaccines. My name's Ian Town and I'm the chair of the COVID-19 Vaccine Technical Advisory Group. This group is in its third year of fairly steady work providing advice to the Director General about our vaccine program. And as we near the end of this calendar year, I'd like to give a big shout out to the members of the group who've worked very hard. We've had over 50 meetings and provided nearly 45 reports to the Director General over this time. And I'd really like to thank the Science and Technical Advisory team that do all the work behind the scenes to make sure our advice is evidence-based and clearly stated. So today I'll be providing an update on some of the advice we've provided to the Director General recently, and to reiterate Dr. Old's point, which is we have done very well here in New Zealand with our vaccination program, and the key thing as we get ready for summer is to just give that a real boost for the boosters as we think about getting ready for summer and making sure we're well prepared for the few months ahead. As Dr. Old has noted, a good number of people here in New Zealand, 2.75 million rather, have actually had their first booster. So a big shout out to them. And 650,000 people have already come forward for that all-important second booster from those who are eligible. Now, as you know, these boosters certainly lift the antibody levels, which improves that vital protection against the virus. And with the ongoing number of cases, which, as Dr. Old has noted, are plateauing, there have been exposure to both the BA2 and the BA4-5 variant, and that does give a natural boost to immunity as well, and we call that hybrid immunity. In addition to that vaccination immunity, the exposure to the virus gives a more general boost, as I've said, and increases the levels of protection. And then, of course, if you do develop COVID-19, there are at least 2 antiviral agents which are available for those at greatest risk. So a big shout out to all New Zealanders who are getting ready for summer and getting their boosters. And we've been just looking more closely over recent months at some of the other risk groups for those who may have serious outcomes with COVID. And one of those is to think about eligibility for that second booster. As you know, everyone over the age of 16 here in New Zealand is eligible for that first booster, and currently it's those aged over 50 years who we've targeted for the second booster program, as well as health workers and disability workers over the age of 30 years. And this is in line with international best practice, where those second boosters have been reserved for those at greatest risk, usually because of an underlying health condition, such as diabetes, heart or kidney disease. We've been reviewing some of the data here in New Zealand and recently provided some updated advice to the Director General, and this is to lower the eligible age for that second booster for Māori and Pacific people down to the age of 40 years. And from this Friday, the 18th of November, all Māori and Pacific people here in Aotearoa, New Zealand, will be eligible to receive the second booster, as long as it's 3 months since any documented infection. Now, this was based on clear evidence from data that we've been able to gather here in New Zealand, and this is very pleasing to us because a lot of our early decisions were based on data from overseas, including Australia. So the work that we recently published on the Ministry website looked at all of the recent information about deaths and hospital admissions from COVID-19 here in New Zealand. And what we showed in that work is that the risk of death from COVID-19 is around twice for Māori and Pacific people, and that risk kicks in earlier, around the age of 40, which is why our recommendation has been made as announced. Similarly, they have a 2 to 3-fold increase in the risk of being in hospital. In both these cases, this is often due to the presence of comorbidity, such as the conditions I've mentioned, which tend to occur earlier in these population groups. Now, it is timely to provide a brief update on our surveillance program, particularly the wastewater testing, which Dr. Old has mentioned in passing. As you know, our wastewater testing has been a game changer here in New Zealand and has led us to understand the progress of the virus around the motu. At the moment, we are still detecting COVID-19 in almost all of our wastewater measurement sites, which are a total 82 across the country. Our surveillance has shown, as Dr. Old displayed on the graph, that we've shifted during the middle of the year from that BA2 dominance through to the BA5, which is now being replaced by a number of newer variants again. And we know from the testing that still occurs in our hospital setting that those wastewater trends are also being mirrored in the results that we get from those admitted to hospital. We do expect the numbers of cases of BA5 to slowly trend downwards, as Dr. Old has mentioned, and there are 3 or 4 new variants which may form part of the future in terms of our experience here in New Zealand. So thinking about the next few months and what the approach means for us here in Aotearoa, New Zealand, our advice remains the same. get the vaccinations, and now with this extended eligibility, encourage our Māori and Pacific families and whānau to come forward for that second booster, those that are now eligible and those who are already eligible. And perhaps in coming forward, there's an opportunity for tamariki to be vaccinated, remembering that that vaccination, Pfizer vaccine, is available for those between the ages of 5 and 11. Lastly, I want to acknowledge all of the work that's gone on over the last 2 years from our amazing vaccination teams around the motu, from the far north, where there have been mobile clinics, marae-based clinics, and general practitioners, pharmacies, and Māori and Pacific providers. A huge thank you from us all for the work that you do, and we're expecting that there might be an upsurge in business over the coming weeks as people come forward to get their boosters. Tēnā koutou katoa. Back to you, Andrew.
Thank you, Ian, and thank you, Pete, also. So, in summary, an expected increase in cases, along with an increasingly unpredictable mix of COVID-19 variants circulating in the community, means we need to keep our collective eyes on the ball and make sure we all do our part to keep cases, and by extension hospitalisations and deaths, as low as possible. We remain in a strong position to manage the impact of COVID-19, including emerging variants, with a highly vaccinated population and a significant proportion of us also having had an Omicron infection this year. The recent increase in cases reminds us that, as much as we all wish it were the case, we're not out of the COVID woods yet. We need people to continue to do their part to keep themselves and their whānau and communities safe, particularly over the summer period. As Ian has said, get vaccinated when your dose falls due, test if you have symptoms, isolate if you test positive, and be prepared for COVID when planning your holidays. Now is also a good time to reconsider mask use in certain settings beyond the mandated requirements in healthcare. The 3 Cs are a handy back pocket guide to places where the risk of COVID-19 is higher and where masks continue to be recommended. Those are settings that are closed, crowded, or close contact with others, such as public transport. We're now happy to take questions and invite my colleagues to join me.
Did you consider a booster just for everybody?
Yes, thank you. Our focus, as I mentioned, has really been on those at greatest risk of severe disease. And when we looked at that hospitalisation data, the risk of ending up in hospital for those under 40 is really quite low. And so this combination of our first booster, and remember that quite a large number of people have had that hybrid immunity boost through exposure to BA5, we feel that's sufficient for now. Obviously, around the world, there's a lot of interest in what happens after 6 months, so that we know that antibody levels tend to trend downwards. What we don't know is, does the protection against severe disease start to reduce as well? Once we get more data on that, we may review our booster recommendations. That will occur in the new year, particularly as we get ready for winter next year.
Can you look at all about how to get more people taking up that booster, the one that's available already to them?
Well, we talk about it a lot, don't we? And as I said, the big shout out to all of our community-based vaccinators, particularly Māori and Pacific. There is a bit of fatigue, I think, about some of the messaging, to be honest, and that occurs in any mass health campaign. So the reason for today's push on that is really just to remind people that the boosters are available. We know they work. They definitely protect against the requirement to go to hospital. So that's a really powerful message for everyone out there. And the whole point of this presentation today is to say, before you go on holiday, let's get some of these things tidied up.
What's your recommendation for people that are going to have Christmas parties? Are you saying rats tests first and things like that?
So one of the things that we're working with our colleagues in the National Public Health Service on is a summer checklist. So the exact detail of that and the specific recommendations are still being worked through, but we will expect to publish that in the next few weeks, and that will have a range of things that we recommend people do, considering things like actions that you might like to take before visiting elderly relatives, suggestions around Christmas parties and those sorts of things.
Is rats one of the things being considered?
Definitely one of the things being considered, yes.
You mentioned mask wearing before. Would you say that you would encourage people to maybe start wearing them again on things like public transport now?
Yes, so our advice has been consistent on that, and we still believe that there is good evidence that masks reduce transmission. They protect you from catching COVID-19, but also they protect those around you if you might have COVID-19 and not know it. One of the advantages, of course, we have now with the weather is that there is lots more doors and windows open, people outside. But if you are in settings where you are in close contact with other people, if they're crowded, if it's poor ventilation, public transport, buses particularly are a good example of that, then yes, we think masks are a good idea.
There was a story this morning about the BN1 variant overseas. Do you know much about that or whether or not it's in New Zealand?
BN1?
Variant that's come up?
I know there's, I'm not familiar with BN1. I am familiar with BR2, which is a new variant in Australia. I think one of the things that we're seeing now, and I think we're starting to see commentators around the world talking about this, is this idea of a variant soup or a variant swarm. That previously, when we've dealt with outbreaks, they've tended to be driven by a single dominant variant. We certainly saw that here in New Zealand with a BA2 driven wave and then subsequently a BA5 driven wave. What seems to be the case occurring now in multiple countries around the world is rather than a single variant becoming dominant, a number of variants, often closely related, are starting to sort of compete for dominance, and that reflects the evolution of the virus, but also, as I mentioned, does make it harder to predict exactly what the future shape will look like.
How close are we to getting an Omicron-ready vaccine then?
Yes, so you've probably read reports from overseas that both Pfizer and Moderna, they're the two RNA companies, have both developed both BA1 and BA45 variant vaccines. So we are watching those developments very closely. MedSafe, our regulator, has received an application from Pfizer to consider the BA45 vaccine, the bivalent vaccine. There's not a lot of data about whether or not that is in fact more effective, although the theory is very sound. So once MedSafe have concluded their review, in the new year we'll discuss further with Pfizer if that's an option for us here in New Zealand. They're not able to supply any here in New Zealand this year.
In terms of vaccination for children, so those under 16 aren't yet eligible for a booster. Parents, I understand, are quite concerned. What conversations were had around expanding the booster to those under 16?
Yes, when we looked at that data that I mentioned about risk of severe disease, including hospitalisation, and we looked right down to 6 and 7 month old children and their experience over this last year, the risk of severe disease and requiring hospital treatment in anyone under 16 is very, very low. And so that's where the risks and the benefits have to be thought through more carefully. And we didn't feel there was a strong argument for extending boosters to that age group at this stage.
About planned care. So emergency doctors have asked for more planned care to be scaled back. Is that something that you're looking at doing?
So in every hospital, in every place where planned care has been undertaken, there is always a balance between acute demand on the hospital on that day, so the theatres, the staff, and what planned care is being scheduled for that day. Also includes things like ICU capacity, depending on the capacity. So those decisions are made every day on a day-by-day basis. So when we have escalating acute demand, decisions are made about what needs to be deferred, and clearly the most acute, time-sensitive and important work will be done. So we know across the country, as the number of COVID-19 admissions decreased, that planned care was ramping up, and we've seen that, and we've been supporting that in a range of initiatives. That will be impacted if we start to see a surge of COVID-19 acute admissions again. But at this point, it will be happening in some places, but not spread.
So that you're saying it's not happening enough. I wonder, is that a conversation that you're having with your colleagues around the country about whether more needs to be done to ease the pressure on the EDs?
So one of the things about now with a national system is we have got some greater national visibility about the pressures across the system. So that is something that we are doing now on a daily basis and sometimes more regularly about having a view over what is happening in the different spaces. So support is being provided, both in terms of what needs to happen locally, but also regionally. So we've seen a number of the hospitals now that used to work in their district. We don't have those, but working regionally to support one another. So those are conversations that we're supporting.
At the moment, are there any, like say today or in the last few days, are there any that are only doing that? What in Auckland, I think you call it P1 and P2, that's super urgent. Are there any that are only doing that level at the moment?
Not that I'm aware of, however, I can say, so for instance, here at Middlemore, I know this week we had the most acute number of minutes in our theatres ever. So we had over 8,000 acute minutes earlier in the week. That's a really huge amount of acute work coming in the door. So that needs to be prioritised. So we are doing that. But it still means that the planned care work, I know today it's dropped back down, so we are flexing that, as I say, on a day-by-day level. So even if it's for a short period of time, it's not continuing.
So sorry, so for that 8,000, did you get any planned care?
Yes, so there was still some done, but it just means the balance. It's the time-sensitive work, the most time-sensitive. So usually that includes cancer, but other time-sensitive procedures, we will be prioritising those over the lower prioritised work that needs to be done.
This last one.
Yeah.
Just with this, you know, you're trying to clear that backlog with COVID cases rising, and really there's been very little respite, hasn't there, between the two waves. Are you going to make any inroads into, have you made any meaningful inroads into that backlog?
So we're collecting all that data on the progress on plan care. So as people will be aware, we've got a whole lot of plan care recommendations and a whole lot of activity happening. Next week we will be releasing the monthly update on the progress we're making on that. So we're looking forward to that, but I would suggest that yes, we are facing huge pressure in terms of acute pressure, but also workforce pressure, which means, again, this is not something that's going to be solved this month or before Christmas, but it's going to take some time as we work towards that.
On that, we spoke to one woman who has a broken kneecap, or the family of one woman with a broken kneecap who waited for 7 days for surgery. She's barely eaten in that time. Surely that's not acceptable this week.
No, I think that's a really disturbing story to hear. I don't know about the details of the clinical case, so can't comment on that, but clearly that is not what we would expect, and we certainly need to be supporting every patient to ensure that they get timely treatment. So I'm sure we'll be reaching out to those people and that patient to not only understand where they're at, but to support to ensure that they get treatment on a timely basis.
On that, can you perhaps put the hundreds of people with acute hand, wrist, knee, ankle cases onto the private list, temporarily at least?
So we're doing that. This is in the context of us doing a whole lot of work where we outsource from the public hospitals. So public hospitals can't do all the elective work, so we are now working with those in the private system to do that work, and that tends to be the lower priority, the less urgent work, so that the hospitals can focus on that acute demand and the high complexity. So that is part of what we do, but we are also looking to do more of that.
You talked about the pressures on the system and the pressures on staffing. Have you got an idea of the numbers of doctors, nurses, etc., that you are down at the moment that you need to have desperately, obviously, with this wave that's going to be coming through?
So again, workforce pressures, as I described, are significant in terms of we came into the pandemic now over 2 years ago with workforce shortages, and that has been something that has been really exacerbated by the pandemic. We do know that we not only have those shortages that continue, so maybe 5-6% in terms of the entire workforce, but compounded by winter illness, COVID, and other stress and pressure on our workforce. So in total, across the health system, probably somewhere around 8 to 10% shortages exist currently, but we are working both to recruit internationally, but also to increase our pipeline. But as we've talked about, these are things that are going to take some time. So what we need to do in the short term is to support our workforce. So we do that by working from team to team, healthcare provider to healthcare provider to ensure that we are supporting them, but we're also looking at the tasks that are being done. So we're looking to share some of the tasks. So for instance, here at Middlemore, we have a task team every morning, which are healthcare professionals, regulated and unregulated, who come together to see if they can pick up some additional tasks, for instance, on a ward which has got some nursing shortage, for instance, to pick up and work together under supervision. So we're looking at these initiatives to ensure that we can actually manage the essential work that we need to as we recruit an additional workforce.
So 8 to 10%, what's that in terms of numbers, in terms of doctors and nurses? What are we talking about here?
I don't have those hard numbers on me, but happy to get back to you on that.
Is it like tens of thousands or thousands?
Depending on where you are at, there will be hundreds. For instance, in a hospital the size of the Middlemore, there will be, a couple of hundred, but in terms of nurses, in terms of doctors, it will completely depend on the specialty and the area. So for instance, we might be short in some areas of radiologists or psychiatrists, but we might have our full quota of respiratory physicians and infectious diseases physicians. So it goes specialty by specialty. So it's important to understand where the shortages are. And the other thing I would say is that we are now, as a national system, starting to plan this regionally and nationally, so we can work much more collectively. And so we are looking at how staff in one area can support patient demands from other areas. So for instance, South Canterbury are picking up some of the planned care work because they've got capacity from their neighbouring areas such as Dunedin or Christchurch. So where we've got some workforce and some capacity, we're looking to support those other areas. So this is the joined up system that Te Whatu is now focused on, ensuring that we can actually deliver services more equitably across all of the regions.
Guys, we're going to have to start wrapping up soon, so just a couple more questions.
Just one more on the public transport, please, if you don't mind, from our newsroom. Would you then look to call on public transport leaders to enforce mask wearing on trains and buses?
It's not for us to enforce, to make calls about enforcement. Certainly we, as I said, we encourage transport users to mask up on public transit. I think if you recall, even when masks on public transport were mandated, we still didn't ask bus drivers and people to enforce that. That was very much a message to the community that this is something that we need to do collectively. But I think the message for today is that we do think with cases increasing and projected to continue to increase, that now's a good time to, if you are a public transit user, to reconsider your own mask use in those settings.
Just to clarify, you had the 8,000 acute cases. Was that over a week, was it?
Well, that's minutes. Minutes, not cases.
So what would be?
So normally on a normal, so like today when I was up in the operations centre here, there was 3,500 minutes, acute minutes. So 3,500 to 4,000 minutes on an acute day. On a normal day, a work day would be about normal. So that just shows, and it fluctuates obviously, but I think it just goes to show that acute demand is significant, and in a public hospital we need to balance up, what to prioritise dependent on clinical acuity and need.
Anyone else? No? Okay, thanks everybody. Thank you. Now, if there's any further questions around numbers, Adam, Ryan, just send us an email. Yeah?
And Te Whatu Order National Medical Director, Dr. Pete Watson. Thank you both for your time today. I will start by providing our latest assessment of the COVID-19 outbreak before moving on to what we can do to best protect ourselves and our loved ones over the coming months. I will then hand it over to Pete, who will cover the work underway to address pressures on the health system now and also looking ahead to the summer months. Ian will then provide an update on COVID-19 vaccination, including a recent decision on vaccine eligibility. But first, the numbers. As you will have seen from our weekly updates, COVID-19 cases have been increasing over recent weeks. After 4 weeks of steady increases, the last 2 weeks have seen a stabilisation of numbers, with the 7-day rolling average now sitting at just over 3,000 cases per day. And latest wastewater results also support that trend of stabilisation. However, as you can see here, the number of patients in hospital with COVID-19 has increased slightly as of midnight, Sunday the 13th of November, with 339 people in hospital with COVID-19, up from 322 the previous Sunday. It's certainly too early to say whether the current plateau in cases will be sustained, and as of course was reported yesterday, cases in the last 2 days do show some signs of increasing again. The takeaway is really that the outlook for summer, with more people travelling and with the unpredictable mix of variants circulating, at this point remains uncertain. As always, we will be watching these numbers closely and continue to plan for a possible continued increase in cases and hospitalisations through to the end of the year. The complex mix of Omicron subvariants now circulating makes it more challenging than previously to predict what the future shape of our outbreak will look like. At this stage, there is no evidence to suggest that the new circulating variants leads to more severe disease, but some, such as BQ1.1 and XBB, have shown increased growth advantage compared to other variants. These new subvariants are starting to outcompete more established variants internationally and now here at home, most notably BA5, which, as you know, was dominant recently and is now losing ground, particularly to BQ1.1, accounting for about 78% of cases in this most recent data, with BQ1.1 accounting for about 8% and BA2.75 for about 9%. Overseas, the impact of these new variants has varied between countries, with some experiencing relatively small increases in cases. Encouragingly, in some parts of Europe, a wave of BQ1.1 cases has not yet led to the same rise in hospitalisations seen in previous waves. This could also be the case for us here in New Zealand, particularly given our relatively high level of hybrid immunity from both vaccination and recent infection at the moment. And we're watching closely this relationship between cases and hospitalisation rates. As has been the case throughout the pandemic, our response needs to prepare and plan for a range of potential scenarios, including such as now when the future shape of the outbreak is uncertain. To continue to inform our response, COVID-19 Modelling Aotearoa has provided some updated modelling reflecting the possible impact on case and hospitalisation numbers linked to new variants, as well as accounting for waning immunity and changes in behaviour, which I'll share in a moment. It's important to note that modelling is not forecasting or predictions, and models always have a high level of uncertainty, particularly with COVID, given the unpredictable impact of new variants, population immunity, and now increasing antiviral use as well. Importantly, the impact of antiviral medicines on future shape of the outbreak will be considered by the group with future models. Given the limited real-world information on new variants, many assumptions required for this modelling have been borrowed